Welcome everybody to today's webinar on the topic of what is that bug? Current infectious diseases and their risk to transplantation. We have a fantastic speaker for you today, and I'm very excited about this webinar. Just before we get into introducing our speaker, I have a couple of housekeeping items. For those of you who are brand new to this webinar platform, if you have any questions, we are recording this webinar, and so your lines will remain muted. So on the bottom left-hand corner, you will find a blue icon that has a little chat feature in it. Just click on that icon and type in your question, and we will pose the questions at the end of the webinar to our speaker. Also coming up, and the registration is currently open, is our next webinar on the topic of navigating ethically challenging scenarios. That will be on September 12th, and you can register on our website at organdonationalliance.org. For today's webinar, we are offering 1 Sep-C credit and also 1.2 nursing contact hours, courtesy of Iowa Donor Network. So everybody who's listening, even if you're listening in a group today, I know many of you participate in groups, everybody can claim their continuing education credits or certificate of attendance. All you need to do is follow the evaluation process. So whoever registered your group for this webinar will receive the evaluation email. Please make sure to forward that email to everybody in your group. And for those of you in the group, if you did not get the email, please follow up with your group leader to obtain that email and to complete your evaluation. For nursing, you only have 14 calendar days to submit your evaluation, and for Sep-C, you do have 30 days. So at this point, and I forgot to introduce myself, I am Heidi Aguiar, and I'm part of the Alliance team, and I'm going to be moderating today's webinar. And I'd like to introduce our speaker for today, Dr. Cameron Wolfe, and he's Associate Professor of Medicine of the Clinical Transplant Infectious Diseases Department at Duke University in North Carolina. So Dr. Wolfe is an Associate Professor of Medicine in the Division of Infectious Disease at Duke University. He works with UNOS as the current chair of the Ad Hoc Disease Transmission Advisory Committee, also known as DTAC. At Duke, Dr. Wolfe serves as one of the transplant infectious disease faculty. He also maintains an active HIV practice and has facilitated moving the HOPE Act forward both locally and nationally. He's the Health System Director of Biopreparedness, helping plan for emerging infections that might help hospital operations and patient care. So I'm going to turn it now to Dr. Wolfe to take us through the presentation. Thank you, Dr. Wolfe.
Hey, no worries, Hetty. I'm on the speaker, I'm assuming?
Yes, you are. Great. Live. Thank you.
Terrific. So hey, everyone, thanks for joining in. The irony for an ID doc is I think I've unfortunately caught the respiratory virus that my 4-year-old is currently having, so I'll try not to cough in the microphone, but my advanced apologies if I have to. Just by means of disclosure, there's nothing here that I'm going to talk particularly off-label, but to be clear, although I'm the chair of the DTAC committee, this is not a DTAC talk, this is not a HRSA-approved talk, and this is entirely of my own creation, not in any way the government's. So, as a bit of an outline, I thought if we were going to talk over infections in transplant for the better part of an hour, what I might try and do is actually give some FOCO guideline as that we would often talk through with our transplant fellows about timelines and a bit of a preliminary algorithm of how to evaluate infection risk in some of our patients on the recipient end. We'll then dive into a couple of particularly highlightable emerging and re-emerging infections, and we're going to talk a bit about Zika and West Nile in that list, and maybe some TB and Toxo. And then I was going to end with a discussion of what's happening in relation to our opiate overdose and how that's epidemic and how that's affecting us in terms of HIV, Hep C, and increased risk donation. So with that, look, if all of you only take away one slide from this talk, this is the one slide that I try and hammer into all of our new fellows. This was a slide put together by an ID colleague, Jay Fishman, a good couple of years ago, and he really tried to just instigate a bit of a timeline as to what we should be looking for as clinicians with any of our transplant recipients. And the idea here is that you can really split things up into 3 sort of main blocks based on timing. And sometimes despite all the complexity that goes along with transplant, we sometimes forget that actually in the first good few weeks, particularly the first week, actually the most common things that we run into on an infection side are related to the fact that for most of our transplant recipients, this is probably the biggest surgery that they're ever going to have. And so then typical hospital-associated surgical problems actually sort of top the list for most of us in terms of things that we can run into. Anastomotic leaks, urinary tract infections, line-associated problems, etc. That notwithstanding, though, that's also the same time that very occasionally, fortunately rarely, we run into some more of our catastrophic things, and these are the things that tend to make the front page of the New York Times. So rabies, West Nile, occasionally, fortunately, HIV, the things that are more catastrophic that donors can sometimes bring to the table. It's usually well and truly after that, into the sort of the first 6 months of someone's post-transplant phase, that we then start getting into problems that are more related to the immunosuppression. So these are things that would typically not affect people pre-transplant, but specifically given their T-cell immunosuppression that they run into, can become much more of a problem. PCP, reactivation of any of the herpes viruses, so CMV, shingles, some of the hepatitis can reactivate, and then infections with things that really you ought not see in a healthy immunocompetent individual, such as toxo-nocardia, etc. And so the take home here is that if you think chronologically, you can really split things up into different phases of the illness. There's a couple of things that actually even present much later and are worth just remembering in the back of your head. Occasionally donors can present us with problems that are not necessarily just infectious. And so there's a long history, unfortunately, of donors occasionally donating malignancies. And if you think about it, some of those cancers can take a long time to grow and can present quite late. TB, for example, is a donor-derived infection that by its very nature is inherently slow growing and actually can take sometimes upward of 6 to 12 months to present. And then there's some things that both the combination of a donor-derived infection and someone's immunosuppression can lead to malignancy as well. And the quintessential ones there are when a donor may give you, a recipient, HHV8 or EBV, that down the road with sufficient immunosuppression trigger sarcomas or lymphomas. But for the most part, what I'm going to talk about now are things that can be related to donor-derived problems that occur within the first few months post-transplant. The other way of that we encourage a lot of our fellows here to think about transplant infections is also to think about who comes to the dinner table, and then you can substitute that for the surgical table. So you can think about that three ways. What does the donor bring to the table is the first question. And as you all know, I'm sure there's a very set panel of tests that all of our opioid colleagues will complete on every donor, but that's always by definition an imperfect set of tests. So the first question is, could this be something that a donor inadvertently brought to the transplant table? We'll talk about some of those things when we get into West Nile and Zika a little bit later. The second thing is, what does the recipient bring to the table? So this then factors in, does the recipient already have hepatitis? Do they have a history of latent tuberculosis? Have they traveled to cocci endemic areas? Are they a cystic fibrosis patient with lots of drug-resistant bacteria? The third thing that's a little less expected is, what does the table bring to the picture? And by that I mean, what's the environment where the procurement and the transplant actually took place? Is there something that's unique to that situation, recognizing that this is a multiple step surgery that brings something unique? And I want to just highlight one example of something that tricked us here for a little while. This was a case of an individual who actually presented to Duke, a 48-year-old recent liver transplant recipient who was admitted with fever and abdominal pains for the better part of a week. He was not known to our hospital, but certainly was known to Hyderabad, India, where he had flown and got his transplant. And so initially, as you might imagine, a recent return traveler set the alarm bells working for lots of things that it could have been, as we've listed there. But in actual fact, the more we got some history, this gentleman was transplanted by his good friend, the surgeon. We had absolutely no information on the donor. And in fact, the recipient himself knew that he was on a drug called entecavir for hepatitis, although he didn't know why, which is always a great start. And as you can see, despite lots of exotic potentials, he in fact had some transplanted liver abscesses. The kicker was that in fact he also had some highly drug-resistant ones. And bacteria that would typically not be found in our hospital environment or in fact, anywhere really in the United States. And so, in actual fact, the donor in the end grew some incredibly drug-resistant Klebsiella that's really very typical only to the Indian subcontinent still to this day. And as you can see, for those of you that look at sensitivity panels, I'm sure you can imagine that this is a headache in the making for any physician seeing this patient. So, but the take-home model is you may predict the risk here if you recognize that the table, the environment from which this gentleman had his transplant and for which the procurement occurred, was not our sort of standard sterile technique United States epidemiologic table. It was in fact directly because of his presence in India. So with that in mind, and what I've sort of talked about there is a little bit of framework both in terms of chronology and also in terms of geography. I want to then sort of really dive a little bit more into some geographic infections. And I'm not sure how well this presents, but the picture was intended to simply show the sort of dizzying array of new infections that continue to arrive on our table and keep us all busy. So the first of those is Zika. And my apologies for those of you that have never heard me speak. I use cartoons to be my water break to stop coughing into the phone. So we're going to try and do a little interactive poll question here, and we'll have a couple of these. We'll see if they work. So the first, what's the best test to evaluate a current Zika infection? And I'm going to pose that you're a pregnant female recipient, or if you're on the OPO end, you could consider the donor who's in front of you, who just returned from Costa Rica, and she's febrile. And I'm going to give you 5 options, E being the obviously correct answer, whichever way you look at it. So I'll give, I think if I go to this, you should all see a question that you can actually now answer. So we're getting most responses in here, I think. I'm going to give you a couple more minutes. All right. So I'm going to try Hetty and go back to our previous slide here. By going forward, I should be able to show some results. So 63% of you, or 63% of your logged in computers said Zika PCR, which is actually the right answer here. So we'll walk through these answers as we talk. Clinical exam, incredibly difficult for Zika, but I'll give you some clues in the next few slides. Why did you let a pregnant recipient go to Costa Rica is always a valid question, but our recipients will do different things. IgG is actually a test that really does not exist for Zika. It's a curiosity that is not a very helpful test. And IgM, unfortunately, actually has a really long persistence phase where counterintuitively we think of IgMs as really quite acute, but this can last for 3 to 4 months, if not longer. So the right answer here is in fact the PCR. So moving forward, Zika. So Zika is something that we consider as a sylvatic cycle infection. So this is something that typically does not exist in humans. It's usually transmitted back and forth between monkeys and mosquitoes. But when faced with the right sort of environment, and Brazil certainly found to be that environment, can really proliferate also within an urban cycle. And Brazil proved to be very efficient at doing that because it had never had Zika before. There was no community immunity to Zika. And in fact, it was a situation where there was very close harboring of both human populations and mosquito populations, oftentimes being a long sort of 12-month mosquito season. So when we think about Zika, it's transmitted, of course, primarily through mosquito bites, and 2 mosquito types have proven to be the most efficient vectors. The first is Aedes aegypti, which you see on the top, and then Aedes albopictus. And both of these are actually pretty commonly found for us in the United States, particularly across all of the southern states bordering with Mexico or the Caribbean, but actually stretching quite high up. And these are mosquitoes that naturally will be the ones that you run into on a day-to-day basis, and also, in fact, are the ones that are quite seasonal for us. They also do carry dengue and chikungunya, which we'll talk about. So if we go through the map of these cases, in fact, Aedes aegypti, the main vector, exists in a very dominant fashion, as you can see, through the regional southeast of the United States, but is essentially a tropical-born mosquito. And if we think of albopictus and you look at that United States map, that really extends all the way up to the Great Lakes and is typical, in fact, historically of where malaria, in fact, existed in the United States, proving that seasonally we certainly have had these mosquito populations for a long time. We've learned with Zika that this is not just an infection limited to mosquito transmission, however, and so much so that my dear friends in my home country's Olympic team even issued our Brazilian athletes with Zika-proof condoms. But the message here is that this is both mosquito-borne, sexually borne in some instances, and obviously most critically can be spread in utero, which we'll get to. So from a modeling point of view, we've thought hard about, what would be the impact here in the United States, and therefore how does that impact our transplant programs? And if you factor in a couple of things, both mosquito endemicity, where do the mozzies live, patient and human population size, and how much do they travel? So how much do they go to Florida? How much do they go sort of south of Florida, I beg your pardon? And in fact, you can see that the largest populations of people who travel, who are also endemically surrounded by mosquitoes, of course, are in Florida or sort of southern Texas on the border. That has proven to be true when we look at areas where Zika has extended to, and in fact really all the way up through the Caribbean is now considered endemic. We've had brief periods of endemic spread, as you would well remember, both in Florida and also in Brownsville, Texas, so right sort of down on the border. Although both of these areas, importantly to state, have currently been Zika-free so far this season. What happened last year with Zika is, I think, really representative of the seasonality that we expect with this infection and that would be typical with West Nile and dengue and some other things we'll talk about. This is really solely how often do we come in contact with the mosquitoes that will carry the infection. So for the majority of these infections in the United States, these were in Puerto Rico, although you can see that there was a number of returning travelers who also hit mainland US. But really faded away in the winter as our mosquito populations fell. And so unfortunately, of course, whatever your political affiliations are, this is something that we will continue to face for some time. So let's talk about what it actually presents with. And so for those of you that need to make a bit of money, there's always good research for people who are willing to be mosquito volunteers. God bless your souls. The key with Zika is that this is, for the most part, an asymptomatic condition. So only about 20% of people will feel anything. The rest will be unaware that they are ill. For those that get sick, it's a brief illness. It typically has an onset within a week to 10 days, 12 days of post-exposure from the mosquito, and in total duration lasts about a week. It's a flu-like illness. Actually quite commonly has a rash, which we'll show some photos of, but can actually reside in non-blood tissues for quite some time. Urine up to about a month in some instances, and male semen up to almost 6 months. And that has implications for transplant, clearly, when we think about how do we know what the infectivity of a donor might be, especially when 80% of the donors won't have any symptoms. So the rash itself is very nonspecific. It's a prominent rash, it's a viral exanthum, and would be difficult to differentiate, frankly, from many rashes that can equally be mosquito-borne in the areas where they occur. And in fact, honestly, in my HIV clinic, this would be syphilis until proven otherwise, although plenty of other things that I've listed there can look the same. But certainly if you had a return traveler or in fact a donor who was presenting with an unusual rash and febrile, I do think Zika should come to your mind if they've had appropriate travel. The key is that those same mosquitoes can in fact infect you and carry with a number of other viruses that may in fact be more relevant clinically, including Chikungunya and Dengue. One of the things that's been a challenge for us with the serologic assessment that we talked about earlier on is that they all cross-react. So even if you're trying to prove Zika, it's very hard to actually exclude the other two conditions as well. Treatment, unfortunately, like most viral infections, we essentially have no treatment options other than to say, my underlying comment there, actually if you do see someone back on stateside who you think has Zika, it's important to keep them away from our local mosquito populations. Ironically, we would prefer our mosquitoes not get Zika either. So that's sort of a little take-home point. They also need to be avoid being bitten whilst they're viremic. Then obviously pregnancy is a whole different kettle of fish, which we'll mention briefly. Diagnostics these days have become a little bit more freed up since the FDA actually gave us a wider expansion to allow PCR testing, and this in fact has included some donor evaluations, and I'm sure many of you now participate in work that can allow Zika testing. It's widely available through our community labs now, through Quest and LabCorp, for example, as well. And although there is serology, it's not really helpful in the transplant setting, I don't think, because it's just got such a long lag time, as I said, with also a poor specificity and cross-reactivity. So really, if you do think this is an issue for one of your patients, a PCR would be the way to go. I'll talk briefly for pregnancy only because I set the case up that way, and it's what Zika, of course, has unfortunately become infamous for. So I'm sure we've all seen photos of microcephaly, and it's very sort of graphically disturbing to see a child with such prominent deformities. But from a functional point of view, this is just utterly devastating condition. These children will essentially never be able to complete ADLs. They will not be able to talk, feed themselves, toilet control, change their own clothes. It's a sort of devastating level of neurologic damage, and essentially what we've now sort of recognized is that the skull base can form, growth of the brain early on can begin, but then the normal pressure of brain growth that expands the skull just fades away as those neuronal connections don't get made in the face of Zika infection. And in fact, the whole skull essentially sort of collapses in on itself, leaving the normal appearing face but very small head of the children. And so microcephaly is not something that's new. There's lots of infections that can do this, but obviously Zika just occurred in such a wave in Brazil and the Caribbean that this was prominent for us. It similarly happened in Puerto Rico, and so this is important to think about because we've actually, it's a United States territory. We have OPOs that work there and transplant centers that perform there also. If you look at last year's transplant efforts, actually very little ominous signs came out from Puerto Rico of transplant outcomes being in any way worse. And that has led me to be quite personally reassured that Zika may not be a big issue for transplant, unlike our complications we had with West Nile virus, which is closely related but caused really devastating post-transplant issues. And I think the other reason I'm reassured is that at the end of the day, when we've looked at blood samples from Puerto Rican blood donors coming in through the peak of their season last year, up to 2% of people donating blood, who therefore presumably were well at the time, were actually PCR positive for Zika. So they were infected at that point. And so if you think of 2% of people at any one time who are infected, there's a fair chance that there's a very large number of pregnant women on Puerto Rico who have delivered babies at this point, Zika impaired. And I hope I'm wrong in the sense that there might be a wave of children with late onset neurologic issues coming out of Puerto Rico, but will remain to be seen. From a transplant perspective, as I said, it actually seems to be a relatively reassuring problem despite all the news that would suggest otherwise. When you go back through the literature, there's a couple of cases of liver transplant recipients freshly becoming infected post-transplant from a blood transfusion in this instance, where they clearly had a febrile illness that was consistent with that, but none of the sort of malignant encephalitis that would develop, and they got better. There's certainly some information in people who are immunosuppressed with HIV that it does not appear to be particularly troublesome for them. And actually out of Brazil, who do a lot of kidney transplants, really very little in the way of sort of ominous Zika findings to this point to suggest that our recipients do poorly, which I think is pleasing. What's that led to? Well, it's sort of led to some of us trying to draw our conclusions as to how we think about Zika from a transplant point of view. So certainly it highlights the need for travel screening, as do most of the illnesses that I'm going to talk about today, both for your recipient and also, most importantly, for the donor. I do think understanding whether the donor has had a consistent febrile illness or rash would be important, and this is something where sort of local NAT testing may be helpful. If you're thinking about on the recipient end and you believe someone is acutely infected, I think all the recommendations currently would say that's probably not a wise donor to take, even though I'm not giving a bad picture of the kinds of infections that Zika can create in our recipients. Safety would say that we still have to be pretty cautious. Although I certainly wouldn't extend to the level of excluding donors purely on the basis of their travel. For our living donors, it's a bit easier. If you've traveled, deferring for a month is said to be a very good phase to be out of the window for which active infection may have occurred. And certainly none of our current guidance would preclude donors from being used who've traveled, simply because there are going to be circumstances when using that particular donor is so critical for a recipient who's otherwise going to pass away that a small risk of Zika probably outweighs the risk of the donation itself. Now, different issue if you have an absolutely proven case of Zika, that probably is appropriate in living donation to simply defer. But there's been so few cases of that that's not a concrete recommendation by any means. And deceased donors, exactly the same. If you know that they're NAT positive, i.e. they're freshly infected, that's probably not a donation you should take, but otherwise we could usually actually move forward. The impressive part actually is that somehow this year Zika has not reappeared, and that's different than what was seen elsewhere because, in fact, other countries only clear their Zika once they become immune as a community, and certainly there's not been enough infections in the United States for that to occur yet. But perhaps our public health sort of management so far has actually done better than we anticipated. So with that, I'm going to try and change tack ever so slightly. So a related virus that clearly did cause us some headaches in transplant was West Nile. And so this was really just a quintessential blend of sort of an epidemiologically relevant infection with one that caused unusually and unexpectedly severe events in transplant. So again, 90% of people infected with West Nile have no symptoms, similar to Zika's 80%. Of the remaining 10%, 9 of them will have a brief flu-like illness, and only really 1% of healthy individuals get the true neuroinvasive pathology. That is completely the opposite in people who are transplanted. And there's now actually a series of really very poor outcomes in people who've been transplanted with fresh West Nile in their donor. The majority, in fact, you would be anticipating running into some problems with neuroinvasive encephalitis. And that's hard because it's been tough for us to predict where West Nile will pop up. So here, for example, after the wave of cases that marched across the United States from east to west in the 2000s, here compares to the incidence in 2011 to 2012, just a dramatic difference. And I think it's sort of a PhD's worth of study to understand why seasonally there can be such a big change. I've heard folk from the CDC sort of talk and postulate about bird populations and migratory weather patterns and all sorts of different things that would lead to a higher proportion of infected mosquitoes near people. But suffice to say that this is incredibly hard to predict. Just going back briefly, why it's relevant, of course, is, as I said, the severity of the illness. And so what most OPOs now will do is at least tap into their local blood bank, who do at least have serial screening of blood samples to say, when does West Nile first appear in my community? And once that's there, then undertake sort of very targeted serial testing. Equally, if you're in the recipient end of the world and you're seeing someone who's confused and encephalitic and you know it's July and you've seen your blood bank data that says, in fact, folk locally to you, or more relevantly, local from where the donor passed away, have had some Zika infections, then I think this should be on your radar. We would anticipate more West Nile presentations, unfortunately. Dengue is then the other thing that looks almost exactly the same as both of these viruses, and again is a close cousin to Zika. It's transmitted by the same mosquitoes, so as this map would suggest, it's in the same place. And again, like Zika, it's gone from essentially being non-existent in the Central and South Americas to being incredibly prevalent. We ran into dengue a little bit in the United States, particularly in very southern parts of Florida, as well as Puerto Rico. And although it's died off the front pages of the news, it still exists in the Caribbean. And so certainly if you do have your recipients or fresh donors who've come back from Central and South America, this does need to be on your radar as a febrile illness that can have decent thrombocytopenia, really profound muscle aches and pains as a febrile illness. Does not appear to be that much worse in transplants, but we don't really look for it, so it's hard to know. Its cousin is Chikungunya, which similarly has gone from being non-existent at all in the Central Americas and South America to being widely endemic. And I think if you look at that map, the only reason Cuba is not also dark green is that they didn't report, although it's certainly endemic to that area. So chikungunya, for any of you who have experienced it, is a back-breaking arthritic illness that can actually last for a good few months, and probably does tend to be a little more prominent in our transplant recipients because of, I presume, concomitant medications. But again, doesn't cause the same degree of encephalitis or severity of illness that West Nile can. Again, more of an issue for our colleagues in Puerto Rico. I'm going to try and change topics slightly and talk about toxo. So as a question, we've had some changes in toxo testing over the last year or so in the US. And so I want to ask, who's at the greatest risk of getting toxoplasma? So a lung transplant who's R plus D minus, and they take atovaquone. A heart transplant who's R plus D minus on pentamidine. A heart transplant who's D plus R minus on Bactrim. A kidney who has a propensity for French cooking, or a heart transplant who's on dapsone being D plus R minus. And I'll give folks a couple of minutes to try and pop in some answers. Alrighty, Hetty, I'm going to try and move this graphic, so let's see if I can make it work. Bingo. So, just as I thought, you kind of all spread all over the place. So most critically, folks are recognizing that in fact this is more of an issue in heart transplants than other organs, although interestingly you all think that those of you that like steak tartare are under more stress. And that's probably true for new infections, but in fact it's actually still fairly rare for our cats and steak eaters to come down with toxo. Actually the biggest group here are those who we've intentionally, knowingly or otherwise, given a D plus R minus heart transplant and not given them Bactrim. So E would in fact be the correct answer here. So one of the things that we now in fact recognize is that, let me try and go to the slides. We now have the opportunity in fact to test for toxo, and are testing all of our donors. So for those of you that know in fact that you have a recipient who's seronegative, a donor that's seropositive, especially for the hearts, they are the greatest risk. And so typically those many heart transplant centers will be using Bactrim anyway for PCP prophylaxis. It's got a great protective ability against toxo. But for different reasons, Bactrim may not be the ideal choice for certain patients if hyperkalemia or renal function or sulfur allergy come into play. In actual fact, of the other PCP drugs, atovaquone has a little bit of toxo activity probably, whereas really dapsone and pentamidine probably do not. So you can make active decisions based around pneumocystis prophylaxis that in fact really help you from not coming down with toxo as the heart recipient. It exists in other organ systems, but is clinically much less common. We changed things across in the United States to move from just the heart center running the test to the OPO running the test up front for a couple of reasons. One is that there had been some mortal outcomes in non-heart recipients, albeit they rare. But the other part is that it was actually, we ran into a whole lot of communication errors when heart transplant teams wouldn't necessarily have access to the donor blood anymore. They wouldn't be able to find it. They weren't reporting back to the rest of the recipients from that organ. And I do hope that now that we at least can see our donor toxo testing in front of us, that we can make choices based on prevention that can really have an impact. So you should all be seeing an IgG as the test that you see for your donor. And if you know you're in an R minus D plus situation, you can then really talk to your ID guys or clinicians about directing toxo prophylaxis accordingly. So in terms of other emerging pathogens, the one thing I want to always remember is TB. This is sort of the great imitator for us in ID about a condition that can essentially present in any way. TB, for those of us who are immunocompetent, presents just like that X-ray. Classically cavitary upper lobe changes on a chest CT and chest X-ray where extrapulmonary dissemination is abnormal, whereas the completely opposite occurs in transplant. In fact, extrapulmonary TB is common. Unusual and more rapid presentations are common. And then we typically also have the problem that in an immunocompetent person, those of us who've been exposed to TB in the past, actually the vast majority of us take latent TB to our grave and will never be sick. Whereas, in fact, latent TB in a transplant population runs, quoted anywhere between a 50% chance of reactivation. And that can be either from the donor or, in fact, from the recipient. From the donor's end, you're going to know mainly based on where they grew up. I'll get to that in the next slide. But the issue here is if you know that your recipient has had TB exposure based on the test, you can do something about prevention, whereas the treatment is really very challenging for us. There's lots of drug interactions and lots of toxicities. Where in the world do we get TB, literally? Where in the world is Wally sort of question is totally geography. So we do get TB in the United States endemically, but it is actually on the decline, whereas nationally, TB rates in the US are actually on the increase, mainly because of immigration patterns. And so it's become important for us, I think, to really understand not only where did your recipient grow up and where did they spend time, but also where did your donor go. Clearly the list here, including much of Central South America, Africa, and Southeast Asia. Living donors with TB, you can usually figure it out. TB is something that does have fairly clear presentations, but again, for the living donor who's well, TB actually exists in many, if not all, tissues, even for people who are in their latent phase. So understanding what the person's TB skin test or quantiferon is really helpful. Understanding where they grew up is probably the most important part. If I have a living donor who wants to donate and who looks completely well but actually grew up in South Africa, I'm going to be far more concerned than a domestic donor. I'm just going to skip forward for purpose of time. So these days, of course, we do also have a little bit of difference that you may have noticed creep into your clinical practice with types of testing. And so many of you, I think, will have, like us, transferred across to quantiferon testing for TB. Really, both of these tests, unlike quantiferon and skin testing, both essentially look at your cellular T-cell immunity and say, hey, do you recognize mycobacterial antigens? They're not very helpful for testing active infections, but they can be really effective at looking for exposure. And so what we can do, is compare the two. And so PPD testing have been around for decades. They're very cheap. It's easy to apply. It's really hard to read. A PPD screen, many people will think of the redness, whereas in actual fact it's related to the lump that a recipient gets. You've got to get people back at the right time to measure it, which can be hard if you're doing an evaluation for someone who lives out of town. It's hard to get an intradermal needle in place. It actually quite stings. Whereas a quantiferon is essentially doing all of that stuff in a test tube. And so although it's more expensive, for example, we made a decision here that this is more efficacious for us because it doesn't rely on people being accurate to read the test. It doesn't rely on us getting our patients back for more screens. And unfortunately, none of them are valid in donor assessment. So there have been studies looking at whether or not you can do a quantiferon on a soon-to-be donor. And in fact, the giant steroid response that you get at the time of pre sort of terminal event makes the test almost invariably hard to interpret. So again, you go back to your geography. One final question here. We're going to get into some hepatitis and increased risk stuff. So what is the hep C transmission risk from a NAT-negative donor who died with a heroin overdose today in the United States, or an eclipse period infection? And I'm going to give you some statistics. and hopefully by the end of this can knock off anyone who would say, what is an eclipse period? So let's see if you can give us some answers. I'll give you all 10 seconds. Alrighty, let's see where we got. So, again, a bit of confusion amongst the audience. This is always a teachable moment. So all of you claim that you know what an eclipse period is. That's great, because I'll be honest, I didn't know the term when I was well into my ID fellowship, but we'll get back to that. So in actual fact, it's about 1 to 3%, and the numbers are a little challenging to really calculate, and probably depend a little bit on where in the country you are and what the local hepatitis incidence is in your IV drug using community. But it's a little more than we would have instinctively thought, and I want to go through this. It's certainly, fortunately, not 30%, or I think none of us would be wanting to take these donors. So to summarize this bit to begin with, one of the things I think our patients sometimes get confused with, and maybe our clinicians too, is increased risk does not equal poor quality. I have to say this to my recipients all the time, who say, "Oh, you know, doc, I don't want to take those bad organs." So I said, "No. Well, hang on. This has nothing to do with organ quality." And in fact, that's been a particular issue in some folks who've needed this translated into Spanish or other languages, where the inference of increased risk has been translated to mean kidneys that are, or livers or hearts that are not as good. And clearly, this is nothing about what we're talking about here. We are now in the world where HIV positive donation is possible through the HOPE Act, which we'll talk about. And then I think we're in a situation now where we need a real serious rethink about the way we consider Hep C. Previously to 2015, it was not even required to do Hep C testing on our donors, nor any way through UNOS to list recipient and donor NAT positivity. And so we sort of lumped all HCV testing together. Whereas actually these days I think most people would say there's a dramatic difference between the donor who's antibody positive and NAT negative, i.e. cleared, versus the donor that's still viremic. And so I think you'll increasingly see people trying to talk about donors being HCV viremic versus HCV seropositive, or truly HCV negative, and consider those as different risk strata. So let's talk about what we're sort of going through. So obviously there's window periods both for serologic testing and NAT, and that certainly helps us, like it's looking specifically for the virus, not just your response to it. Certainly has helped us, as that table shows, cut down the window period pretty dramatically, certainly for hepatitis and HIV, Hep C and HIV. But there still exists a little period where you may have a little bit of hepatitis or HIV in your blood, enough to infect a donor, but not enough to be turned positive on the test. And that for the NAT at least is our eclipse window. And it still sort of exists really out to 5 or 6 days. And so this becomes a relevant issue when our number of donors who are dying of IV drug use are sometimes dying with their hepatitis C infected needle right in their arm. So when the CDC and others have modeled what would be the likely risk, it's pretty clear that not all increased risk donors are the same risk. So, as many of you know, some of the risk factors that we look at for our donors can in fact be things that occurred up to 12 months ago. The key there is that the likelihood of you being in a window or eclipse period from a contact that happened 6 to 12 months ago is really just zero. So for our folks who've been in prison, for our donors who've had partners with high risk exposure, if it happened many, many months ago, I tell all my clinical colleagues that the risk honestly is vanishingly low. However, if you look here, the risks are quite different, in fact, based around NAT certainly helps, but if you look at that IV drug using group, that's where we come down to about 3% as a modeled risk factor for in fact, even the Hep C NAT missing the issue. That'll be different depending on which part of the country you're in. Why is this relevant? Well, we're in the midst of an opiate epidemic, sadly. It's been this interesting dilemma for transplant populations that we've now seen a huge number of our organs increase because the number of opiate deaths have really shot up. So, I mean, the number here is just breathtaking to me that, 50,000 people died last year of drug overdose. And as you can see from the inflection on the curve, I think despite whatever our politicians would say, that number is going to be higher by the end of this year. That has had an impact on the number of donors who are coming forward who are antibody positive. And what we've seen is that our Hep C community has changed. It's actually moving away from baby boomers who have not had such an impact on transplant of late and moving towards young donors who have been recently infected through intravenous routes. So what's the sort of use of these donors so far? Well, currently it's actually not a lot. There's been a slow trickle, I think, of people in the thoracic community at least using Hep C positive lungs, but really very few willing to do it in that group. Certainly in our livers, this has been a little more common. And so when we've looked through UNOS data and tried to find, how many people are taking donors who are antibody positive, NAT negative. So these are non-viremic and in theory cured patients. How many of those are being used? And as you can see there, 134 livers, 80 kidneys, and basically nothing in the thoracic realm. We've taken that at Duke and actually thought, well, hang on, here's an opportunity. So when there's been a modeling actual study out of a group in Washington who've looked at, how many of these donors are we turning down? How many more organs could we transplant? It's in fact not an insignificant number of people could get donations from folks simply by thinking about the way that Hep C antibody positive NAT negative donors really should not be viremic and therefore not infectious at that point. These are people who would have either cleared the infection by themselves or been on therapy. The other thing that's changed for Hep C is the medications. So we are now in an era where cure of Hep C is the expectation. And that's been taken a step further by now a couple of pilot studies that you may be aware of intentionally giving Hep C negative recipients of kidneys Hep C positive donation and just treating them straight away afterwards. One group at Hopkins, led by Christina Durand, and then another group, which I'll get to from Penn, have done this. And as you can see, percentage of undetectable Hep C in the recipients very quickly rises to 100%. So they've essentially given someone Hep C, treated them out of it. Now this is early pilot data, but it's still very helpful. In the Penn group there, you can see every single person of them viremic up front when they got their kidney that was infectious with Hep C and almost straight away cleared of their hepatitis. So this may in fact become our new norm, I'm not sure, but certainly something to think about in the near future is, should we just not worry about Hep C because we know we can treat people out of it? I'm approaching time, so I do want to sort of skip forward, but this is an important key here. So we will have and expect to have an increasing number of people in hepatitis C who are antibody positive but NAT negative. And so we would often argue, and in fact there's a consensus paper that's about to be released in AJT that would say these donors should be cautiously approached as being really not currently infected, certainly not infectious to the best of our sense. There are a number of centers, mine's one of them, but there are others who are already using these organs, and certainly for even for people where intentional mismatch, intentionally giving them hepatitis-infected organs would now seem possible. It's important, one clarification. When UNOS expects reporting for these sorts of issues, we ask, can you report based on what's expected? And if I give someone a NAT-negative viremic organ and they turn positive, that's expected. But we would argue that if you're using a donor who's antibody-positive, NAT-negative, and your recipient gets hepatitis, that is an unexpected outcome for us. It's no longer good enough with better testing to say, well, the antibody was positive, therefore this was sort of anticipated. That's not the case. If you're dealing with a NAT-negative donor for Hep C, that is an unexpected outcome, irrespective of whether the person died as an IV drug user or not. And we would actually want to hear those stories, because they not only have relevance to the sort of our sense of how much hepatitis is out there, it may have huge relevance to other organ recipients who used that donor. I'm going to end quickly by not that hope, but this hope, and that's the use of HIV organs. So we've increasingly been able and capable of using HIV recipients to go through transplant, and certainly from kidneys this has been now very common, and also certainly livers, although to a lesser extent, and a scattered number of hearts and lungs across the country, recipients who are positive. Really the revolution here has happened again in medications. So the picture on the left was what a patient of mine about 10 years ago had to take as her daily cocktail. I can't even begin to imagine the side effects that she felt. These days the standard for me is to offer patients one pill once a day. And so that sort of revolution has dramatically improved their ability to be healthy, to tolerate their meds, and to therefore be well enough to receive transplant. Further, it's also allowed us to think about what about donors who are positive. And so you may be aware that we're well underway of using HIV-infected donors, specifically in this instance for HIV-infected recipients. And so far, a number of people have been transplanted under the HOPE Act, both livers and kidneys and combinations of the above. Then really, so far at least, looks to be pretty good. Most of our non-US experience actually comes from South Africa, where the rates of HIV in their community are so high that they've had to felt necessary to use those people as donors. And in fact, their outcomes, when we compare both graft survival for HIV patients receiving HIV donors and compare them against regular recipients, HIV recipients getting regular donors, in fact the outcomes are basically the same. So here we go at 3 years at about 85% graft survival. And if you look at patient survival, obviously more importantly, again the number's pretty similar, so about an 80 to 85% patient survival at 3 years, similar again to sort of historical HIV data. So I don't know how many of the centers on the line would actually participate in the HOPE Act, but certainly this was something that preliminarily we had modeled a few years ago that maybe up to 500 extra donors would be available through this. It's not worked out to be quite that much so far, but certainly something that I think people are still very optimistic about for our HIV population, and actually almost runs into this interesting ethical situation where they now have the potential to use even more donors than their HIV negative recipients do. I answer that by simply saying, look, if they can get an organ that was otherwise unavailable, that frees up another organ for someone on my waiting list to receive. So I think the ethics are a moot point. And so with that, I want to conclude. I know we've got, I'm at sort of 10 minutes heady to 4, but I can equally stay on a little bit later, and I can see some vivid chat here off to the left. So let's work our way through some questions.
Thank you so much, Dr. Wolf, for a very, very educational webinar and lots of information. So that was fantastic. And just as a reminder for all of you who are listening in, if you have questions, just submit those through that chat box on the left bottom hand corner. Just type in your question, and I will pose them for you to Dr. Wolf. While we have the question and answer time going on, I do want to put up this last poll. I think that was fun having those polls. Thank you, Dr. Wolf, for including those in your presentation. For those of you who are listening in a group, if you can complete this poll and let us know approximately how many people in your group, that would be very helpful. The first question is more of a clarifying question. When you were talking about the HCV testing,
yeah,
you were referring to antibody testing.
Yeah, no, I was. Yeah, it was meaning antigen. So there actually isn't a Hep C antigen test per se. So I'm not sure if you're thinking about Hep B, which certainly is more relevant to Hep B surface antigen, which really refers very clearly to infectivity. For Hep C, typically the only test that yeah, that's all right. For Hep C, typically the only test was really that we used to have was an antibody. Now we actually have the ability to tell, are you currently viremic, yes or no? I can see, Lisa, you've got a question there about any... Oh, sorry, Hetty, you go.
I'll pose the question to you. That way you can just focus on the answer, and that way everybody can hear it. So are there any issues with getting Hep C treatment paid for when transplanting a Hep C positive donor kidney to a Hep C negative recipient?
Yeah, that's a really great and topical question. So I'll preface my answer by saying I'd really encourage folks to read the AJT Hep C consensus guideline document that'll come out in a couple of weeks, because it really does specifically go to this question. It is an issue, I think, and it's, Hep C therapy, whilst being curative, is not cheap. It's sort of 50 to 100,000 depending on what the drug is. And so, we are in a situation where currently, at least, I think there's a lot of desire for this to only happen at the moment within the realm of research, where groups have engaged very carefully with pharmaceutical companies to make those drugs available. I think it's a very different scenario if you're sort of out transplanting intentionally hepatitis and then run into an insurance company or a pharmacy that says, no, you can't have the drugs, because then you've got yourself into a mess. So, that may be different in a couple of years' time once there's enough data to say that, look, this works really well. Because I think if it's as effective as the preliminary data would suggest, I think we will down the road be able to make a really interesting financial argument to providers and payers that say, look, there's so many extra donors here that can be used safely that the cost saving by transplanting our patients up front considerably outweighs the cost of the therapy. Now, at this stage, that's a prediction only, and so I think in the absence of that data, your question's very right. You have to think about that, and I think that's why companies are currently being approached to say, look, can we set up some studies to help prove that?
So I may have missed this in your when you were presenting on the Hep C piece. Currently, would the practice require an IRB approval for Hep C positive to negative recipients? Is it
so there's not a sort of law that I'm aware of that would require that for hepatitis, whereas there is actually statute that does require it for HIV transplant. But I think there's a community desire to say, look, this is very preliminary data so far for Hep C mismatched transplants. And I think if I was going to do that, I do think doing it under the umbrella of an IRB gives you not only institutional protection, but really allows patients to be fully consented and aware of what they're going to be doing. Although there's no formal sort of documentation that says this must happen that I'm aware of.
Great.
Now that's different to the HOPE Act, where in fact the NIH stipulate this will be done in a research environment. The research information will go back to the Secretary of HHS for sort of understanding of safety. This will be done under the IRB umbrella. That's very clearly written down that it has to be.
Mm-hmm. Another question for you, are there different types of dengue? For example, I've heard of people mentioning hemorrhagic dengue. Are there different types, and how does that affect patients and donors, recipients?
Yeah, it's a good question. So there's not only different strains, but there's also different presentations. And so the strains per se, as far as I know, don't necessarily cause all that much different illness, but there is the sense that once you've had dengue once, the second time you get it again, your immune response can be more significant, and in fact you can end up with much more hemorrhage as a result. So it's someone's first episode and first run-in with dengue is significant but rarely fatal, whereas their subsequent ones, they can actually get what's sort of colloquially termed hemorrhagic dengue, I guess, as a complication both of the virus but also their immune response to it. Now you apply that to a transplant realm, and I guess it's in theory that you could have someone who 5 years ago had dengue, survived, and became a recipient. And if you were to transplant that recipient with donor-derived dengue, you could run into much more trouble, although I suspect that's a rare circumstance.
Right, yeah. That would be very unfortunate. You were referring to West Nile virus earlier in your presentation, and you mentioned 1% of them are neuroinvasive. I suspect this was a case that I dealt with many years ago now, but to this day it kind of plays on my mind. We had a donor case that had West Nile virus, but it wasn't diagnosed until several days after death and after the donation had occurred, and recipients, 3 of the 4 recipients, actually died as a result from their transplant. from this patient, and we went back to look at the chart to try and figure out if we missed anything in the chart. And the only thing in terms of clinical documentation that we thought maybe could have clued us in was a very high white blood cell count on the spinal fluid that was scribbled somewhere on a chart on the side. Is there something else we could have done? Is there anything that could help us clue in that a patient might have West Nile virus?
Yeah, that's a great question. I'm sorry for this clinical scenario because often no is the easy answer to that question. So, 90% of well people will be completely asymptomatic, and 90% of the remainder will at best have a flu-like illness that they may or may not be capable of reporting at the time when they become a donor. So it's almost the expectation that donors are not clearly visibly infected. And then in terms of, I guess the second part of your question is really, is there a laboratory way of giving you a clue ahead of time? Maybe in that circumstance, the interesting thing would have been, why was that donor evaluated with a lumbar puncture? Because that would suggest that they may have had an encephalitic or at least presentation with confusion. And so in that circumstance, I think you can get some clues by looking at the white blood cell count in the CSF if someone's presenting with an encephalitic presentation that's otherwise unexpected. But that doesn't in any way come specific to West Nile. There's lots of things that can cause leukocytosis in the spinal fluid, but that presentation, if they were in fact encephalitic, would have certainly raised questions about that donor, not just for West Nile, but in fact for many transmissible encephalitides. That said, we probably take a lot of donors who present confused and may have a few white cells in the CSF and yet are in no way infectious to their recipients who do well. So that becomes a bit of a clinical assessment, and I would urge OPO colleagues, if they're in the setting of trying to evaluate someone like that, to be prepared to have a good chat to the clinicians who did the spinal tap and really sort of say, hey, what's your degree of clinical suspicion here? The other part of your story that's telling is the penetrance there, isn't it? So you've donated, that donor donated to a number of recipients, many of whom got sick. And that is the take-home point in the standard for West Nile, is that this is a widely disseminated virus and can and often does make many recipients sick. And so, again, the point, I guess, of a lot of the UNOS notification systems, for example, are to say, look, if you think your recipient's got an illness that might be consistent with an encephalitis, or you've proven they have West Nile, make sure you report that, because, heck, there may be another couple of organ recipients out there with symptoms that their clinicians have not yet fully figured out, who could, gain some valuable time by knowing that your person was sick.
Yeah. Well, Dr. Wolf, we have reached a few minutes past the top of the hour. Really appreciate your patience in addressing the questions. And I want to thank all of the participants who stayed on and listened in. Thank you for your time as well. We wish you a wonderful rest of the week. And thank you again, Dr. Wolf. I'm going to move us back into the speaker room. And everybody else, have a wonderful day.
Thanks, everyone.